Hi everyone, this is Neel Raithatha, consultant audiologist and director of ClearWax. Thank you for joining me in another video using the WAXscope. And here we have a patient who attended with bilateral fully occluding earwax, and I'm just commencing with their left ear first. This is the ear that they primarily reported symptoms with, and the symptoms included reduced hearing, otalgia, which is ear pain, and also some intermittent tinnitus. So tinnitus is any sound that it originates within the ear or inside the head, so it's not an external sound that you're hearing. And it can be one of the symptoms of earwax impaction, and upon a removal, quite often, patient's tinnitus will alleviate. It, of course, all depends on the underlying cause for the patient's tinnitus. Patients have tinnitus for many reasons, so it may not just be due to a wax impaction. So just to give patients realistic expectations, we always say that if it's due to the wax, then the likelihood is upon removal the tinnitus will alleviate, but there may be other underlying causes for their tinnitus which may require further investigation. So this patient has been suffering for a couple of years. They did experience some symptoms back in 2022. They visited their GP, who advised that they've got wax. The problem in the UK is that the majority of GP practices no longer offer NHS removal of earwax, which is basically available free of charge on the health service. So this patient just used some drops at the time, which did reduce some of their symptoms. However, quite often with drops, it's a short-term fix. It can soften the wax just enough to create an opening so sound can get through. Unless you've only got a small amount of earwax, drops is not really going to clean your ear out of the wax. Instead, the purpose of the drops is a softening agent. It helps to soften the wax to quite often facilitate the removal by a professional. Sometimes using drops short-term can cause an exacerbation of your symptoms because the wax itself absorbs the drops and it causes the wax plug to expand and swell, creating more of a blockage. So this plug is quite deeply located. You can see I'm just trying to wriggle it through past the second bend. You can see the canal wall around between 3 and 6 o'clock. And this plug is larger than that section of the ear canal. So the drops helps to soften the wax plug so I can bring it through this narrow aspect of the patient's ear canal. I never realised quite how much hairs are formed within a wax plug until I had used the WAXscope. It's probably not as easy to see and detect with an endoscope, but you can see with this wax plug here, there is quite a few hairs there, and that's becoming more noticeable with most wax plugs that are removed, just the amount of hairs that are found. And of course these hairs are found at the outer third of the ear canal, and as they shed, if they don't fall out the ear, they're going to amalgamate with dead skin cells, sebum, which is an oily lipid secretion, and also emotional sweat secreted by modified sweat glands. And all of these components together form into earwax. So I think from the angle I'm using, I'm going to go more to the anterior canal wall there, and I'm just going back to the posterior canal wall, and in the distance you can see this wax plug is breaking away. I just put some more medical grade olive oil because it was blocking the suction tube quite a lot, so I'm hoping the oil will help to lubricate the inside of the suction tube so it just helps wax travel up the tube instead of getting blocked. So it's quite dark, so it means it's been there for a while. I'm just dragging it down from the roof of the ear canal there. And now I've got a hold, I've got a grip of this suction plug, of this wax plug, and I'm slowly bringing it through past the second and first bend there to the right. I think it breaks away a little bit as I'm bringing it away. It's now just a matter of clearing up all the broken up debris. And then we'll get a good visualization of the patient's eardrum. There was some scar tissue anteriorly and superiorly. So if that's just localized to the patient's eardrum, which it appears that it is, we call that laryngosclerosis. If it's also affecting the ossicles, the 3 bones, that scar tissue, just calcium deposits, we call that tympanous. There is a slight attic retraction there, but there's no skin formation, so no risk of a cholesteatoma forming. I did ask the patient whether they had previous grommets. There's no evidence of that, but they did report chronic childhood infections. And now moving on to their right ear, I put the olive oil drops immediately because I just didn't want it to block the suction tip. I'm just going to loosen this, give it a little wriggle motion from the base of the ear canal and also from the posterior canal wall. This plug came out in a singular piece, if memory serves me correct. So although it was fully occluding, so there was a complete blockage of air and sound around the edge of the canal wall, it wasn't impacted, it wasn't up against the eardrum like their left side. So I've brought it past the first bend there, just to the left, and I'm just going to curve this around because the front section of the ear canal is an S-bend, a sigmoid shape, so we're going to bring that through. And this eardrum looks far healthier. There's no real signs of a retraction. We can see the posterior malleolar fold. That's where the pars tensor, so the main body of the eardrum, connects to the pars flaccida, the top section. So we're looking from the center of the ear right now to about 9 o'clock. You can see that bend. We call that a posterior malleolar fold. I hope you enjoyed that video, guys. And if you're interested in the WAXscope, please do email info@clearwax.co.uk. Thank you.